And Dr. Kamal is going to talk on capsulorhexis extended, what to do.
He is also another innovator in our camp here.
Thank you, Dr. Sudhanshu. Thank you, Doctor. Good morning. I'm sorry I'm a bit late. I got hurt, so I just took a little bit of physiotherapy and I'm here. So I'll be talking about the anterior capsule. Most of the times we are taught, what are we fairing? We are fairing the posterior capsule or we are fairing the endothelium. But anterior capsule needs to be faired too. So we will just see some situations where actually the anterior capsule has its tantrums like a young kid and how to manage that. So we will be seeing some helpful tips. So before we go anywhere, we need to see what all can happen. You could have your keratome penetrate the anterior capsule. You could have an intumescent capsule cataract with a small pupil capsule running out. While doing rhexis, you could have a subincisional runout, which is pretty difficult to manage. You could have a subincisional runout in an intumescent cataract. You could be doing a femto cataract and you could be having a runout to the intumescent cataract. So we'll be seeing beautiful videos. I've got more than 42 small videos for you for whatever you can think of in anterior capsule. So some basic principles you need to understand first. The thickest part of the capsule is anything between 5 to 9 millimeters. So that's why you restrict your rhexis between 5.5 and 7.8. Don't go beyond that. But the moment you start going beyond 7.5 millimeters, another problem starts. That's where the zonules are inserting. So if your capsule hits a zonule, the zonule by its inherent nature will try and pull the capsule out if you do not have enough anterior chamber pressure. So what you need to do is you need to relax your zonules anteriorly. So if you relax your zonules anteriorly, they will not pull the rhexis out. So once you've understood this, now I'll get into the physics. This is actually how the anterior capsule is and posterior capsule is pulled by the zonules. And this is the zone where you should be restricting your capsulorhexis. Now you need to balance the pressure, the interlenticular pressure and the vitreous pressure into the anterior chamber. The anterior chamber pressure has to be higher than them, only then the anterior capsule will be flattened. If you have a flattened anterior capsule, which means your anterior zonules are relaxed, so you're in a safe zone. So there is a play of physics here. The centrifugal and the centripetal forces are working it. Centripetal is the force which is pulling inwards and centrifugal is the zonule pulling it outwards. You need to have more of centripetal forces to have a smaller rhexis, and you need to have more of centrifugal forces, then the rhexis will start going out. I hope you understood this. Now we go to the next level. What happens and why does the rhexis go out? Number one, if you're touching the zonules and the zonules have more pressure, which means that anterior chamber pressure is less. Number two, while doing the rhexis, you're so focused on the rhexis, your wound is leaking, viscoelastic is coming out. At some point, you go near a zonule, visco comes out, rhexis runs out. We'll see beautiful videos of that. Hypermature cataracts, you flatten the anterior capsule, you started the surgery, but the intralenticular pressure is very high. So whenever this fluid leaks out, there's a sudden burst of change of pressure between the intralenticular pressure and the anterior chamber, and that has an explosive effect, and you have an Argentinian flag side. So once you've understood that, I'll just demonstrate what happens. This is what a capsule is in a cut section, what is happening. As you're pulling in, suppose the pressure in the vitreous or the lens is higher, the lens complex starts moving up. So once it moves up, the anterior zonule is pulled. So this is what happens when the visco leaks, and this pulls your capsulorhexis out. So I'll be showing a technique which I've developed, and it's in publication for Journal of Cataract Refractive Surgery. Now this is most feared thing, making sure there's no run out. This is an intumescent cataract, totally turgid, there's fluid in. So I take a 26 gauge bend needle, I bend it backwards, bevel down. I go at the junction of the inner 2/3 and outer 1/3, one fast jab and start aspirating. Don't wait, go in and start aspirating. The syringe should have some water in it. It should not be pure air because you will not be able to create the vacuum. And once I've reduced the pressure, so we have a straight linear line there. Now I enlarge my wound because initial wound is small because I don't want the visco to come out suddenly. Once the wound is enlarged, I go in, I use a 1 hour, I create a linear cut. Now I have a T. Now this T has 2 flaps. In case one flap starts running out, I have another stepney. I can rotate the capsulorhexis from the other side. So I've made sure now I do a roll technique, which means I push more viscoelastic on the top because if there is any fluid collected behind the cataract, that should get compressed and come out. And now you start, and I'll just go fast forward. Now this is simple. So one, complete half, and then use the other hand to complete the other. The advantage is you can make any shape, any size with this technique. So I call it the T technique. Now in case you already started having a peripheral runout in intumescent cataract, what to do? Again, T technique to your rescue. Now this is an intumescent cataract. You can see the chamber is flattened, the pupil is pushed forward. I'm making it. This is one of my assistants, junior associate surgeons doing the surgery, and she's operating, and suddenly she sees a run out. I'm standing next. I said, okay, wait, I just take over. I push in viscoelastic. I use the same technique of reducing the interlenticular pressure. I push in viscoelastic. I'll just fast forward. Push in viscoelastic, flatten the interior chamber, and then again do the same thing. We'll skip it. Go into the lenticular space, suck out the fluid, reduce the pressure again. And once this is gone, the initial linear cut which is created by the needle is again converted to a T. Now we see a T, converted, include the peripheral extension, and there you are. You saved the day. So this is the T technique. Now this is an interesting situation. Again, this is a recording from one of my surgeons. The peripheral extension has happened and the person is not following the simple diktat, flattening of the interior chamber. So we'll fast forward and see what happens. There's a lot of pushing, pulling happening. And there we'll jump in and see what has happened. We have a PC opening. There's a run out. So what could have been done, we'll see in the next video. If there's a peripheral extension, make sure relax, panic. Do not keep pulling at the tag. Push in viscoelastic, flatten it. Hold the capsule as near to the advancing edge as possible. And with one jerk, bang 90 degrees to the peripheral extension. One jerk, break it. Do not hesitate. There was so much of hesitation there. Pull, push, pull, push. Hold it, boom. So that's what happened. So now this is another interesting case. See, we'll see the same thing now. There's a peripheral extension, you'll see, holding near the edge, and one go and you just pull. So initially pull it to the center and then tangential and complete it. If there is hesitancy, you're gone. We'll be seeing very, very short videos now. Again, similar situation. So this is tricky. You're nearly subincisional. So use a scissors. Use a scissors. So I'll use a scissors and nip this part, because I know if I try and pull this, I might actually go subincisional, because the vectors can never be perfect in subincisional. When you're going to go hold under subincisional, you lift the anterior capsule up in the wound and the wound leaks. So you can never have a good pressure. Okay. This video I'll show you. Most of the times when you're so busy doing the capsule, you don't see the tag coming out of the wound. This tag will run your rhexis out. Never continue a capsulorhexis like that. Always a good idea to use viscoelastic from the opposite side, cut it from the side, pull it in, and then continue. Thank you. I think I could just show you 9 videos out of 42. Thank you.
Thank you, Dr. Kamal, for the really